essentially what Dr. Mangara is doing next week, Wednesday, he is doing an epicardial ablation of the left atrium. So what he does in the procedure is he does an incision, subxiphoid, uses our cannula, pericardial window, to get access to the left atrium. So essentially, this is what he ends up doing. Through our cannula, he will end up using his scope so that he can actually see everything, and then we have a catheter this is 3 centimeters long. It will actually suction to the atrium, and he will burn in between the pulmonary veins. So he's essentially taking out the whole posterior wall of the left atrium so that it makes EP's job that much easier versus having to go in and spot weld from an endocardial procedure. So that's essentially what he's doing. So the patient's gonna come to you guys. Oh, let me backtrack. He's also on Wednesday. Patient's gonna have a left atrial appendage clip, an AtriClip. So patient will probably have 3 or 4 ports they'll come in with, because we're gonna be clipping the appendage. So essentially taking the appendage off of the atrium. Considerations for you guys. Patient's gonna come with drains, both places. And I had said, like, for med-wise, defer to Dr. Mangara, but typically patients will start any of their like pre-procedure antiarrhythmics, anticoagulation meds, whether he wants them on steroids that night, the night of the procedure. For the drain management, you're looking for roughly 70 cc's or less of serosanguinous fluid during a couple of shifts, because then the next day you can typically pull the drains. If you see frank red blood, call Mangara. That's the only thing that we're really concerned about. Patient is definitely going to complain about chest pain because we just burned their whole left atrium. It's not ischemic. It's going to be more focal, but that is definitely something that they're going to complain about. And that's why I say, Dr. Mangara is still working through. I had emailed him kind of protocols, because every hospital does it a little bit different, like what meds they will put a patient on, whether they're using colchicine, are they using steroids, are they using IV Tylenol. So I don't totally know what his protocol is going to be yet to manage that, but just something to look for. He before was talking about the patient probably staying in ICU and discharging from ICU, because it's typically about 2 days that the patient stays post-procedure. If they discharge from you guys, the big thing that we're educating patients on is pericardial effusion. That's the one thing we want them to look for. So if they 15 days from now have chest pain and they present to the ER, that they make sure that they tell the ER that they have this procedure so they don't get this full ischemic workup when it's a pericardial effusion. And honestly, that is pretty much the procedure. I mean, you're managing pain. I mean, the thing is, I'm assuming you guys have seen, you've seen VATS, you've seen a pericardial window. It's just they're gonna be together, and it's your typical management. Questions? I mean, it's really, I know, it's not super it's not rocket science. Yeah, so that's it.
All right.
Yeah.
Yeah, so they'll come back with 2 chest tubes? Is
They will
that the
come
drains
back
that
with
they?
2. Yeah.
Okay.
2 chest tubes, yep, 2 drains, yep. Here,
Like mediastinal and a pleural?
yep,
Okay.
yep.
All right.